Thank you, Paul, and good evening. By way of full disclosure, I just want to say I did attempt to try and conceal my academic identity tonight by deciding not to show a PowerPoint presentation, something that sort of is synonymous with an academic presentation. But then I realized I betrayed myself by the inability to shed my tie, the true sign that I am a healthcare provider, not an entrepreneur. But what I'd like to do tonight is take you on a journey, if you will, through where I think the UVA Health System can play a seminal role in the further development of the creative Charlottesville economy. But I want to begin at a very high level and suggest to you a novel concept that I think is often lost today in the incessant debate about healthcare reform. And that is to suggest to you that healthcare reform does not have its origins in politics, despite what you might think. The origins of healthcare reform find themselves in two colossal forces, one of them biological and the other demographic. The biological force takes the form of the changing face of human disease. We've moved from human disease that was about acute infection to a set of chronic conditions that besiege individuals for decades of their lifetime. And the cost of caring for those chronic conditions is far greater than in the historic model of acute infectious disease. And the second and equally compelling force is our changing demography. The fact that as our society ages, the fundamental social program of our lifetimes, the Medicare Trust Fund, founded in 1965, was established for 20 million retirees at age 65. And was expected to cost $267 per beneficiary. In 1965, when President Johnson signed the legislation, there were 5 working Americans contributing to the Medicare Trust Fund for every 1 retiree. Fast forward to just a decade from now, 2027, there will be 90 million Americans age 65 and older. Their life expectancy will have changed from 3 years in 1965 to 17 years. In 2027. The average cost for Medicare beneficiary will rise to $11,500, and there'll be only 2 working Americans for every 1 Medicare beneficiary. Those 2 forces alone are sufficient to place 2027 as the year in which the nation's expenditure on just 4 programs, Medicare, Medicaid, Social Security, and the federal debt, will exceed total U.S. revenues. That is the genesis of the crisis of healthcare reform. That rising costs of healthcare over the last 50 years now today create untenable choices. In 2027, there will be no money for education, no federal money for education, no money for defense, no money for the environment, unless we deal with the incessant rising costs of healthcare. Secondly, I would say that if our goal is universal access, then healthcare must become affordable. And with respect to affordability, there are 2 courses. The current policy course is to cut our way out of this, to reduce reimbursement to providers like UVA and others, and to reduce benefits to patients. That has ultimately a short-term benefit, but in the long run will result in limited access. Just to our south in North Carolina, 40% of primary care providers no longer accept Medicare or Medicaid because they simply can't afford to. So cutting our way out of this, as the mayor suggested, is a fork in the road that I would suggest has only short-term benefit. The long-term opportunity in healthcare is to improve our way out of this. And improvement requires better outcomes at lower costs through executing on process excellence, meeting patient need on time, the first time, no defect, no error, no waste. $1 trillion of the $3 trillion we spend on healthcare is estimated to be spent on things that add no value. And if we can recoup that $1 trillion, we save the American healthcare system. Now, not only do we have to focus on improvement and process excellence, the elimination of all complications, but we also have to increase productivity and efficiency. Productivity and efficiency are equally critical to affordability in American healthcare. But this cannot be achieved simply by driving human performance harder. We need to achieve productivity and efficiency in healthcare through a technological revolution. And I would submit to you, healthcare delivery, not just healthcare discovery, as Nikki just described, but healthcare delivery is on the cusp of a technological revolution. So at UVA, we are going to focus on two critical technological platforms in a way to improve productivity, increase efficiency, reduce cost, while we perfect the process excellence. So those two platforms are something called predictive analytics, and the second platform, telemedicine. So predictive analytics is the ability to take large amounts of clinical, social, and demographic data, put them through algorithms, and predict what the natural course of illness would be. Today, that's predicated upon my ability to look at you for about 5 minutes during the course of your visit and decide better, worse, or about the same. But if one can harness all the physiologic data that we capture through the electronic medical record and through monitoring systems and use predictive analytics to decide who is getting better, who is getting worse, who is staying the same, we think we can begin to interdict at a point where we can really begin to make a substantial difference and reduce cost. Examples of this at UVA include our AMP3 program, a locally developed biotech corporation where in our neonatal ICU, 45 beds of infants under the weight of 2 kilograms, who can't tell you when they're going to get sick, have been continuously monitored with 6 measurements of blood pressure and heart rate and oxygen tension forced into an algorithm every 6 hours. That predicts which of these babies, preciously and critically ill, are going to get sick. And when you know that 6 hours in advance, you can intervene. The result of that, a 32% reduction in these infants dying of unanticipated events. Thank you. Scale that up, create a partnership that we bring to Charlottesville, a partnership with MITRE Corporation, a federally funded research and development corporation out of McLean, Virginia, highly known for their work in the defense industry to create predictive analytics on the battlefield, and they are bringing their algorithms to us so that we can feed physiologic information in, so we can begin to predict how are you doing not just in the hospital but at home. What if once a day you put your finger on a pad, it recorded a bunch of information, it was brought to your doctor, and that doctor could tell you daily, was your blood pressure better, worse, or the same? Was your diet better, worse, or the same? Was your cholesterol better, worse, or the same? Prevention cannot be achieved by a once-a-year visit to your primary care doctor. It is a daily intervention. That can only be done through these kind of analytics. The second platform, telemedicine, is something UVA is proud to be a national leader in. We are the largest telemedicine program in the Mid-Atlantic region. And last year we did 12,000 telemedicine visits, where no longer do you have to hear the infamous words, the doctor will see you now. It is rather, the patient will see me now. And through telemedicine, we can begin to interact with people in their place without traveling in and out of Charlottesville, without encumbering the complexities of interfacing with the institutions of healthcare provision. And we have a great example of that in our partnership with Locus Health, about what you heard earlier today, a platform that emanated out of UVA that now provides technology available at home that allows us to continuously monitor individuals and reduce substantially by about 50% people needing to be readmitted to the hospital unintentionally. So this challenging time in healthcare is a time where UVA is going to invest, and it's going to continue to bring new technologies to these communities, which will spawn not simply, as Nikki suggested, this discovery platform, but new technology platforms for healthcare delivery. Thank you very much.